Got it. Hi, my name is Subramanian Swaminathan. I'm an infectious disease specialist at Gleneagles Global out of Chennai and Bangalore. So, having been trained in the United States and coming back to India, for a lot of people is a little bit of a culture shock unless you're used to the system here. I mean, often forget what healthcare is and the dynamics of it unless they've done more than just their basic training. For those who have finished their entry-level training, their basic medical degree, and then moved on, they may not be aware of the economics or the scale of it. And therefore, for a lot of people who come back, it's a little bit of a culture shock. And also understanding that all the rules that apply in the United States do not necessarily apply back home. For example, you wouldn't be thinking as much TV as you would in this country. So that's a simple difference. And it takes a lot of time to get over that kind of a mindset and try to reacclimatize to this a developing country kind of situation. Second, also remember that in developing countries, most doctors are multitaskers. The joke used to be that we are also part-time community health workers. So there's really nothing much we don't do. So you never know what you'll be called to do or you may have to step into. Some of us are fortunate enough to work in kind of ivory tower institutions, which may be really big academic centers or in a corporate sector where they may understand the value that you bring in. But for the most part, at least, it's kind of difficult because in a setting in a third world country where the doctor-patient relationship is far more deeper than it is possibly in a first world country, you have people falling back on you for advice on things which are way beyond your own domain. And saying, I don't know, may not necessarily go down very well with them. Yes, over time, you teach them that it's okay to say, I don't know. But at least you are expected to come up with some answers and answer some questions. Some which you may find personally discomforting. Also, that the concept of personal space is a lot more different in a developing country as compared to a developed country. The lines between personal and professional life often gets blurred, and people want to get into your personal space as well, not because they mean to do you harm, but because, by and large, it's a very inquisitive society and they want to know your business and they want to be part of your life.
That is so interesting. In Nigeria, the healthcare tourism industry is about $1 billion industry.
Wow.
And a lot of Nigerians currently seek for and actively go to India for healthcare.
Right.
And
yes.
Considering that, healthcare has a larger population to take care of, we were wondering if there are some specific lessons that you think could be translatable towards addressing that regard.
I think when you talk about healthcare, it's too large a domain for us to be tackling it. You need to look at it in terms of what is that is necessary for the country in terms of primary health and what is cutting edge, which may add value. The point is, without getting your basics, going for cutting edge doesn't really solve your problem. America is a great example of that. Mm-hmm. Every country for that matter is a great example of that, more so in America. And India is also the same problem. We have extreme differences between children dying of malnutrition and we have organ transplants. The center I worked in, we are the largest organ transplant center in the country. In the last 2 years, we've done 150 lung transplants. We do a heck of a lot of liver and heart and kidney and whatnot. So obviously, it's a study of contrast. So it's a bit of a culture shock for most people to see that we do this kind of work in a country which is like this as well. Mm-hmm. I think you can't divorce one from the other. You need both. You need to have ivory towers which will help people look at it and say, okay, you know what, I have a future here. Because the problem is once people start getting educated, especially when they go overseas, they really don't want to go back to their country of origin because they believe that opportunities are going to be few and far between. Mm-hmm. And they are not going to get the due respect. It's not so much about the money. It's more so about the fact that they may not have the recognition that they would get, or the fact that their value may not be understood.
And if you don't have that, right, and the quality of life too.
Absolutely, absolutely. See, the quality of life, you're going to have a different set of quality of life. I mean, I get to call my own working hours. I get to choose what I do. So there are advantages to that. There's no way I'll be making what I would make if I was back in the United States. But having said that, I have a lot of other advantages going for me. I can choose my own working hours. I can choose what I want to do. I have a lot of flexibility that way. But having said that, yes, quality of life matters too. And I think unless you have centers of expertise which can attract and hold on to those kind of people, you can't really go into cutting edge work. And that will help people aspire to stay back in their country and work in the country. And I believe in a very circuitous way, it will also help in improving education in the system, because there will be people who say, you know what, if I train well and if I read well, I can get to this kind of level. But beyond that, I think also primary care needs to be shored up. And I think at least in the south of the country, we are doing much better with regards to primary healthcare delivery as compared to most other parts of the country. Kerala is doing an excellent job. I mean, I don't know if you've seen that. They managed to flatten the curve faster than anybody else in India. They're doing a fantastic job. UK and many other European.
As to whether there was one, I mean, it's a package. And I was thinking it is probably contact tracing. The efforts in contact tracing was the most important one, which I have failed to see whether how much United States.
I don't think we've done a lot. So historically, United States doesn't have as strong epidemiologic controls, especially regarding infectious diseases, than developing countries. If you recall the situation with Ebola, it was similar. That wasn't something that kind of like had started here. And I think this is partially a lesson that we're learning on how important the non-medical acute care is so important in the prevention of the disease. So it's important that you brought that up. Regarding what you were talking about primary care, you're making an excellent point. The basis is the building blocks. You have to have that. At the same time, the specialist care is important for then once you kind of get to that point. It's just really difficult when you have a country that has a minimal amount of healthcare resource, and you have a structure that requires a significant amount of support outside of the immediacy. How do you think that issue could be solved? And
I just want to go back to the Kerala issue for 1 minute though. While you say contact tracing is probably the most important, I would disagree with you. I'll tell you why. Do you know the number one predictor? It's faith in the system.
Okay.
It's faith in the system. The people believe that the public healthcare system works for them. And that's why they were able to control the Nipah virus outbreak last year as well. It's not the first time Kerala has been able to beat things. They beat the Nipah virus with just about 3-4 cases. It was amazing. I believe that, whenever they have a new case, they interview the patient and the whole district is on high alert waiting for the route map of the patient to be published.
Really?
And everybody looks at the route map and immediately goes to the nearest center and says, okay, I was there at that time when this person was there.
Really?
It's belief in the system. It's not that other people are not doing contact tracing. The problem is people don't believe in the system and people don't think it's important for them to cooperate with us.
Mm-hmm.
Unless it's an all-in effort, even the best of resources will go for waste. And to me, Kerala is an example of how they managed to get the faith of the people behind them and work as a unit to get this under control. I think that's important.
And that's
Anyway,
what
coming back to
our governor is also trying to tell in his everyday speech, saying that I'm trying to make people understand so that they will believe what I say based on facts and not just emotional.
Yeah.
Absolutely. Absolutely. See, that's where I think there's a lot of difference between Kerala and many parts of the country. Because in many parts of the country, there's really not much faith in the system. And people are generally wary about what the government says and what the government does and things like that. So I think being open and being perceived as trustworthy is key. But coming back to the question that you asked me, I think this is where entrepreneurship makes a difference. See, India was no different in terms of the landscape of healthcare about 35, 40 years ago. Back in the 80s, beginning of the 80s, we really didn't have any major hospital chains or system. We just had a lot of mom and pop kind of hospitals, no different from any other part of the world. But the point is, all it took was one visionary, the Apollo Group. One guy, he said, you know what, I have a dream and I'm going to set up a center of excellence. He set up one in Chennai and there's been no looking back. The point is, if there is an entrepreneurial spirit and if there is a political system which is willing to say, let's invest in this, it can make a big difference. I'll give you another example. Organ transplant in my state, Tamil Nadu, is the highest year on year for any part of the country. This is only because of the political leadership. The chief minister at that time said, I'm going to back this because I think this is a good thing. And so much so that she really invested in it and she empowered people. And we have an example of a state hospital doing liver transplant successfully, right? At very low cost. So for people who can't afford it in the private sector, there is a public sector enterprise which can do even liver transplants, and they do it very successfully. So the point is, it takes a little bit of political vision and, more importantly, entrepreneurial zeal. All it needs is one person to say, why can't I build a large hospital? Understanding the dynamics of the local economy and targeting what I can do. See, the problem is people try to build ivory towers where there is no scope. You have to look at what is it that takes people from Nigeria out of the country, right? If they're going out for healthcare, why are they going out for healthcare? What are the common reasons? See, bone and joint issues, don't tell me we can't build a system where we can get state-of-the-art bone and joint kind of care. There are enough Nigerians in the United States, orthopedicians and bone specialists, who can easily be called in to fill in that gap, provided there's a good facility being made available for it. And so on and so forth. We start looking at the low-hanging fruit, whether it's cardiothoracic bypass surgeries, whether it is orthopedic issues, certain things like that, you can easily develop it. You need one entrepreneur to say, you know what, I have a vision, and start that off. If there is political backing for that kind of thing, you don't need backing. You just need to make sure they don't interfere with it.
Okay, yeah.
And that will set it up.
Just don't obstruct. Yeah, yeah.
See, that's exactly. Just get out of the way. Let us do what we do best. All it requires is one person to do that. And then you'll realize that it will start off a chain reaction. See, Thailand, same thing happened. All it took was one entrepreneur setting up a facility. And now they are a major center for healthcare tourism. You know, people from all over the world go there. China's taken a leaf from that. There, the Communist Party has taken it on. And they do a lot of healthcare tourism. Please understand, more liver transplants happen in China than anywhere in the world for that matter. As long as you don't ask where the livers came from, you're fine.
I think that's very illuminating. What you're saying is you're absolutely right, you know, and the experience has borne that there is value and there's been success stories in each of the paths that you're outlining. I think that's very insightful. You know, I'm struggling a little bit. I'm just trying to understand, how do you get faith in the system? So what is it that made the primary care stronger, that it was so strong that the populace have felt like this is our primary care and they're following the guidelines and succeeding in it?
Okay, it's a multi-pronged answer. For the first part, politicians should stay well away from it. Second, the politicians should empower people who, see, it's like this. Look at it. When you know who comes up on stage to give the daily press briefing in the White House, people are wondering where the person you want to see is. You understand what I mean? Without taking names. Right? Exactly. You need a trustworthy face to be the face of the driver. He needs to be the person driving it. The second, the right people should be empowered. It's not just people who are scientists, because unfortunately, scientists are not necessarily, when I mean scientists, I mean subject matter experts, which could be health department people, doctors as well. But unfortunately, doctors have this tendency, at least in India, to talk about everything that they have no clue about.
Right.
You know, in India, one problem is we have the cardiologists and cardiothoracic surgeons and liver guys talking about everything in healthcare,
Right.
including COVID-19. So, in fact, one of these big guys was interviewed by a foreign channel when somebody asked him, so what is the BCG vaccine used for? And immediately spot out smallpox. So the point is that I think it's also important to ensure that the establishment understands that you need to have public health experts and epidemiologists being part of it, right? So there are people like that available in every country. The sad part is just that they are unsung heroes and nobody really cares about them. They need to be empowered. And a very good example of that in our country was our HIV/AIDS response. The government said we had been screaming hoarse saying we should be giving antiretroviral therapy free for all people. Then suddenly one day the government turned around and said, okay, we're going to do it. And then we were all left puzzled. We were wondering what to do. I was part of it, and I know how the discussions went on. And WHO was backing me because I was trying to keep certain of those crazies at bay. And we managed to put together a team which could work and advise the government in such a way that would make a difference. And it has made a difference. India has been a beautiful model for HIV/AIDS care. I mean, there are a lot of other good models as well. But for us, our state, my own state, the State AIDS Control Society was revolutionary because it was the first one that was established by the government. And after that, the international agency said every state has to model it after Tamil Nadu to have a state AIDS control agency, to be a nodal agency to do everything. The point is there are already beautiful, role models available. What you need to do is pick some of those role models and look at it in terms of acceptability to the local culture. Because not everything that happens in another country is appropriate for another country.
Absolutely. That is
Right.
is true. True. Yeah.
Exactly. So people have this, genuine ideas of just pulling something out of another country and saying, let's run with it. And then saying, why didn't it work? Well, you know what, it's not going to work because culturally people are different. Their practices are different. The way you do things is different. So you need to respect that and then come up with an answer. But, to be very, there are some low-hanging fruits. See, mother and child care is something that is easy. Why do I say that? Because remember, any hospital, when it starts off, very honestly in India, they always target mother and child care. Why? Because if you get a pregnant mother into the hospital, the baby follows suit. And if you get the baby into the hospital, the rest of the family comes in. Right? So that's the way to capture the family. It's going to take a little bit of time, but it's worth the effort, because if you improve MCH care, not only do you improve the outcomes for the next generation, but you also make sure that the rest of the population follows suit and comes into care. So I think it's absolutely important that you start with mother and child care, and it has to start with the mother. The pregnant mother cannot be forgotten, because it starts with, say, you talk about nutritional supplementation. That's a great way of doing it, because it will improve mother's outcomes and baby's outcomes. Start with nutritional supplementation. If the government is willing to give out free nutritional supplementation, that's a great way to start. Get the mother into care, get more institutional deliveries going, then get the babies immunized. And from there, you spread out to the society. That's a great way of ensuring that you have buy-in from the community for your primary care model. And in the south of India, I would say it's the MCH approach which has really improved belief in the system. Right? There will be, of course, crazies and outliers and all that stuff. Let's not worry too much about that. But for the majority of people,
that has played a role even in the coronavirus
of course,
approach.
Of course. See, in every country there are crazies. See, I was very disappointed when Joker said he is an anti-vaxxer. But what can be said? It doesn't mean educated people are bright. There are stupid educated people too. So education does not necessarily mean it makes you smart. It just gives you some technical knowledge. That's it. But having said that, I think starting with MCH care has always been the best roadmap to getting health services into a community. Acceptance of it. And this is the model that's been used all across Asia, and it's been used successfully as well, including Vietnam. So I think that's the area where you need to focus on. See, women's health, it's just like you say, when you educate a woman, you've educated her family for the next generation as well. The same way you get the woman into healthcare, the rest of the family follows into healthcare. So I think that is probably the biggest driver.
Helpful in this approach to the next few weeks of coronavirus as well, aiming the...
Why not? See, why not? Remember one thing. See, as long as there is something free being given, nobody's going to turn it down. No, come on. That's world over. That's world over. Okay. If you have doubts about that, wait for the next Black Friday.
See what happens. So, like, how have you guys been seeing the same respiratory presentation and outcomes in the hospital? And
fortunately, sorry, go on.
No. And then also for the patients who have been discharged, are you seeing any particular kind of health elements that are prevalent?
Okay. One, too early. The problem is, or the advantage is, the lockdown has worked quite well, actually. The lockdown that the government has imposed has actually worked quite well. Much better than any of us even suspected it will. It's not that it's been perfect, but the numbers are few and far between. Why do I say that? Yes, when the government puts out numbers, you're always this skeptical person who's saying, are we sure that these are not doctor? I'll tell you what. We have our own WhatsApp group about all the infectious disease guys across the country. And we can say with good certainty that outside of certain places, like some parts of Bombay, we are not getting overrun with severe respiratory illness.
Okay.
Unlike Italy, where we had all the elderly people ending up in the ICU fairly quickly, we are not seeing that. So to me, it looks like the numbers are reasonably genuine.
Okay.
No part of the country is really sinking that badly. It seems to have worked quite well. It's also possible that maybe our transmission dynamics are different. Maybe there is some benefit to the BCG vaccine, and that's why we are not falling so ill. I don't know. I'm not going to speculate on all of that.
Yeah.
I know. Well, those are all possible. But having said that, what I will say is that our numbers have been fairly low. We have been looking, but we are getting very few cases. I think the number one cause would be the lockdown. So at this point, at least, it's too early for us to say what is happening. And I will tell you very honestly that some of us have been in touch with the government through certain back channels, and we've been providing them with some certain input. We had actually talked to them about, no, seriously, we had talked to them. Colleague and I had written up a paper about what to do after the lockdown in terms of demarcating areas so that you can have, based on transmission dynamics and opening it up cautiously and upscaling serological testing and things like that. And the government has adopted it. Oh, you're recording this. Okay. Be careful about what is. No, I will tell you that quite a few of the suggestions that we have sent up to the government have been picked up. I don't care about us not getting the credit for that. It's just that it's important that the right ideas go to the government. Otherwise, you're going to have crazy stalking nonsense, and you end up in a soup where you only have yourself to blame for not doing what you could. So I will say that my government has been fairly responsive. They've taken on the right kind of decisions. They have made some mistakes, but for the most part, at least, they have done some course corrections, and they have made sure that things don't get out of hand.
Mm-hmm.
And as far as testing is concerned, they are also developing indigenous system. One of the institutions in Trivandrum, they have actually developed a lamp technology. I believe it's working very well. My colleagues from the inside have told me it's working very well. So if that can be upscaled, it will make population-based testing so much faster and so much easier.
Yeah.
So there is a lot of work happening, and I think we are in a significant, cautiously optimistic. It's still going to be a bad hit, but I'm still cautiously optimistic.
That's good. So 2 last questions. One is, are you getting antibody testing yet? And the second is, are you using chloroquine, and what have you seen with that?
Okay. So antibody testing, the problem is, this is a place where the government made a mistake again. Why they ordered for all those kits from China, in spite of us saying, please don't buy it from China, I don't know. Mm-hmm. Obviously, please understand, it's still a third world country. There may be other issues at play. Mm-hmm. I don't want to speculate on that. But however, whatever it is, the ICMR was smart enough, the central agency was smart enough to pull all the kits, and they have released a message now saying that the performance is extremely variable and it's absolutely useless. They're blacklisting both of these companies, and they have advised that all tests be sent back.
Wow.
I have been informed off the record that Indian-made kits are pretty much ready for prime time. Mm-hmm. We are expecting a notification fairly soon. This has been transmitted. This information has come to me through certain other channels. I still have to verify this, but I'm reasonably optimistic that we'll have our own antibody-based test fairly quickly.
Okay.
Maybe in a week's time.
So that'll be manufactured in India?
That's correct.
Have you seen the information in Senegal regarding the $1 test? Is it a similar kind of that would be?
I will put it like this: if you're getting it in Senegal for $1, these guys will probably make it for 50 cents. Mm-hmm. Remember, we are the vaccine manufacturing hub of the world. We make more vaccines in India than anybody else in the rest of the world. Something like 50 to 80% of the world's vaccines come from India. And the Serum Institute and certain other players have already been in touch with Oxford Institute and a few other places to upscale the manufacture. And they said, if you give us the go-ahead now, by September, we'll mass produce and get the vaccine out.
Really?
Yeah, these guys, please understand, we have some really brilliant people. They have this humanized, what's it called? Chip. it's a humanized mouse model vaccine, whatever. There is a humanized mouse model of vaccine efficacy. There is oh man, we have somebody, one of my teachers actually, Gagandeep Kant. So we have some brilliant people in this, so they can predict how well it will work and things like that. So based on mouse models itself, we don't even need to do human experimentation. There's a lot of work happening. It's just that a lot of it is quiet, and the government is not too interested in pushing into the vaccine segment at this time. They're waiting for the foreign guys to do the vaccine and then give us the tech so that we can mass produce it much faster than anybody else is. But I do believe there are other people who are experimenting with certain who are looking at vaccines in India, but I don't think it's at any decent level as yet. But I'll tell you what the government is doing. The government is going hammer and tongs at using convalescent plasma. Yeah. So there is a major push towards collecting convalescent plasma from people who survived. Yeah, I know. This was one of the things that we had pushed about 2.5 weeks ago. This is one of the things we said, look, don't trust medicines. We are not sure that medicines are going to go anywhere. In fact, we are very confident that none of the medicine options we have right now are likely to answer this question. Mm-hmm. Therefore, we think we should start stocking up on convalescent plasma. So the government has been aggressively following up those people who have cleared the coronavirus and possibly immune, because we really can't do protective antibody titer. So convalescent plasma is starting to be used. I believe in Delhi last week they used convalescent plasma.
It's not, I'm sorry, it's not quantified. It's just if you're positive, the assumption is, but you know, there's a spectrum of the antibody response. So
correct, yeah. Correct. So in fact, we had suggested pooled plasma.
Okay.
Mm-hmm.
Okay.
See, this is exactly what we do. If you have a yeah, exactly. No. See, if you have a pregnant woman who's exposed to chickenpox and she's not immune to it, in the West, you would give varicella zoster immunoglobulin. In our country, VZIG is not available. So what do? We give pooled IVIG because most of it will have a lot of antibodies to varicella zoster. So right now, what they're doing is they are looking at patients who have confirmed history of COVID-19, who have cleared the virus by negative PCRs, waiting for 14 days after that, and then taking the plasma from them. But going forward, their plan is if they come back test positive by antibody, they will start accepting them as well as donors. And this is very similar to what the FDA has given an advisory. Mm-hmm. Because if you look at the advisory for convalescent plasma for the United States, they have said either antibody or prior PCR with a negative PCR. Mm-hmm. And of course, it would be nice to have antibody titers. But I think pooled plasma is the way forward. And in a country like India, where you have a lot of young people, this could easily be leveraged because in young people, you'll produce a lot of titers of antibodies and you're going to have a very low level of illness. So I think this will be the way to leverage our population advantage and try and see how we can mitigate it. I believe in Delhi, they had 6 ventilated patients in a hospital. All 6 of them responded to convalescent plasma and they were extubated.
So we had our convalescent plasma, you could only get it in a research protocol, and that to kind of get going. And so a lot of the patients, by the time they got it, were already so advanced in the progress of the disease. Correct. But it was very heartwarming to note that there was not a lot of reaction to it. It was tolerated. Really.
And I personally, I also have anecdotal instances of clearly seeing prevention of intubation in a patient. And Friday evening, they gave him that, and Sunday morning I come, he's walking in the room.
See, the thing is, the Indian Council of Medical Research has put out protocols for this and had requested for applications as a research protocol. Please understand, even in our country, it's a research protocol. But within 48 hours, they got 99 applications, and the numbers have gone up since then. Yeah. So they are looking to license as many centers as possible, obviously with IEC and all that stuff, with the ethics committee approval and things like that. But they want to really push this forward as a research protocol, but to be available to as many people as possible, so that they can finish the study in as short a period as possible and then make it acceptable form of therapy, and then start collecting pooled plasma for use as therapy. I think that's the plan going forward. So they are really pushing forward with this, which is really nice to see.
Yeah, it is. It is.
I mean, given that I strongly believe that the host immune response is super key in the morbidity and mortality, I'm hoping we could potentially use the same convalescent plasma also in the future, if at all there is a second peak, or even if it comes back in waves.
And you'll be able to
when it comes back, not even if it comes back, when it comes back.
Chloroquine?
Look, Chloroquine is a useless drug. Study after study is coming back very, very disheartening. See, there was a meme. One of my colleagues had done a CME on COVID-19, and his last slide was, "This is the longest time that anything made in China has lasted." So, it's true. The point is, everything that comes out of China is now suspect. I would include the data as well. Now, suddenly they've upscaled the number of deaths to us at 25% extra. How does that happen? How does it happen 1 month later? So I'm not willing to accept anything that comes out of China. The good quality studies that's coming out of the Western world is all showing that chloroquine and hydroxychloroquine seems to be disappointing, to say the least. And within our own society, we had put out a guideline. See, the Indian Council of Medical Research had put out a suggestion or a guideline saying those who are at risk, meaning people who are exposed to family contacts and frontline health workers who are involved in COVID-19, may be offered hydroxychloroquine prophylaxis, 400 milligrams twice daily on 1 day, and then 400 milligrams weekly, something like that. This is based on the University of Minnesota trial, which has not even recruited one patient. Right? I checked it about 10 days ago. They haven't recruited even one person in that trial. So the point is that based on that, they have made this recommendation. But they have actually gone on record saying that we do not recommend its use for therapy because it doesn't look like it's working. Right? So yes, chloroquine and hydroxychloroquine are being looked at. Hydroxychloroquine manufacture has been significantly upscaled in the country. But we have told the government that, our request to the government was, please don't look at drug options right now. It's going to take months of testing and for data gathering for us to know. For us, the quick answer is convalescent plasma. If you want to mitigate the disaster, start collecting convalescent plasma and start shoving it to people who have the high risk factors. Those who are on the wrong trajectory, identify them, like Prashant said, before they get onto the ventilator and get them out quickly. I think that's the way forward. But I'm not hopeful about, I'm not too hopeful about drugs.
Well, thank you so much.
Just finishing off, since India and maybe even Nigeria, they have used a lot of herbs and spices.
He's a complimentary guy.
and India is a capital of diabetes, I believe, and many chronic diseases. And I'm wondering whether the host immune response has anything to do with the lifestyle and the food habits, because New York City is very high stress situation. And so is there any relationship between the fact that I'm just curious why India, despite being so so much of a chronic disease burden for the world, how can it still be safe during coronavirus?
See, there are two parts to it. One, if you look at the data from South and Southeast Asia for that matter, mortality seems to be fairly low. We are not sure why it is so. Maybe it's a problem in counting. The other part of it is, if you look at all the healthcare mortality in United Kingdom of healthcare workers who died due to COVID, it is disproportionately very high amongst international people, especially South Asians.
Immigrants, poor socioeconomic status.
No, healthcare workers. Why is it that South Asian healthcare workers are dying more often than the white guys in the United Kingdom?
Maybe they've cultivated the...
I don't know. No, I don't know. I'm just mentioning a statistic. So for those people who say, because we eat a spicy food and whatnot, we are safe.
That's not...
More doctors of South Asian origin have died in the United Kingdom than Caucasians.
Are they using their PPE? Is it the attitude towards the utilization?
It's raw data, so I can't make any further conclusions. I would say there is enough to say that there is something more to it. Let us not jump to conclusions saying that our lifestyle protects us. There's been other fields of thought as well, that oral polio vaccine, because it changes your gut microbiota, could also give us some protection. There is also a school of thought which says that BCG, because of its many immunological properties. One school of thought says India has such low levels of type 1 diabetes because of universal childhood BCG vaccination. If you've seen the Harvard trial on BCG vaccine for type 1 diabetes, you know about that, right?
Harvard, no.
Oi, you should read this. Google this and you'll find it. 2 doses of BCG vaccine were given to about some bad type 1 diabetics, I think about 50 or something. For the first 3 years, nothing happened. After that, all their A1Cs became fantastically controlled. And this was 5-year follow-up. For 5 years after that, they have data.
Okay.
So BCG, it changes your autoimmunity in that the autoimmune mediated destruction of the islet cell seems to be cut off after that. That's the theory. So BCG also has some immunological effects. But would I recommend it willy-nilly for everybody saying it's a great idea, let's give it to everybody? There is a trial ongoing in Australia. But I think to say that that will make a huge difference is not very smart. Why do I say that? Look at Brazil. Brazil has universal BCG vaccination. Ecuador also has universal BCG vaccination for a very long time, and they're still having huge number of deaths. So if BCG is protective, then why are they having this? I think people are looking for simplistic answers. It's possible that there are environmental influences that we are not aware of. There may be a genetic interplay. We know some viruses do have that. But having said that, most respiratory viral infections don't respect all those things. Influenza pandemic, when you looked at it, Spanish flu in 1918, 10% of the world's population died irrespective of where you were. And the country which reported the maximum number of deaths was India. Okay, so I would be very, very cautious about making judgments like that. I think we are yet to see the numbers come in. It's only when you start looking at the numbers, you'll have an idea as to how bad it is. And you know that your own status, what your own status is. See, New York, after more than 11,000 deaths, it's still only at 14% seroprevalence. And herd immunity, that's the data that's come out of New York City. And the herd immunity is estimated somewhere between 65 and 80%.
Yeah, the New York City data, it depends on where in New York City. So it depends
Absolutely.
on where it could be.
Absolutely.
One way.
Absolutely. I mean, when they averaged it out for the whole city, it was about 14%.
Yeah. Well, thank you so much. We really appreciate,
My pleasure. My pleasure.
Picking your brain, and you've given us a lot to chew on. So thank you so much.
Sure.
And we're going to keep this conversation going,
Absolutely.
Maybe later on we can talk a little bit about our stats and your stats and compare notes and see how if there's anything different that we're doing and you guys are doing that can give us a little bit more insight. Thank you so much.
So I think we could learn a lot from you guys, given that we are behind on the curve as regards to COVID.
Right.
So I think it makes sense for us to learn from where you saw pitfalls and avoid them as far as possible. It just doesn't make sense making the same mistakes all over again.
Yeah.
I think we should learn to move forward in a sensible manner and not create unnecessary panic. But I'd love to continue this conversation. Thank you.
Thank you. Take care.
Bye.
Bye. That was nice.